Hi, this is Dr. Mahadevan. I'm here with Dr. Kate Stevens, and we're going to continue on with part 2 of how to read a chest radiograph. And here are our objectives for this lecture. We're going to talk about the importance of identifying the patient's name and the date of the X-ray. We're going to talk about projection, position, and orientation of the X-ray, and then the elements that make up the quality of a chest X-ray: adequacy, rotation, the degree of inspiration, and then the exposure or penetration of the individual X-ray. So let's continue. The first step in evaluating a chest X-ray, or any X-ray for that matter, is always make sure that you're looking at the right patient's X-ray. So look at the patient's name to make sure it's the name of the patient that you're actually interested in. And the patient may have had X-rays done before, so it's very important to make sure that you're looking at the one that was done on the correct date. All of us have made that mistake in our careers of looking at the wrong X-ray because we didn't take the time to ensure it was either the right patient or the right date. Step 2 is going to be to look at the projection. Is it anterior posterior or posterior anterior? The positioning of the patient when the X-ray was shot. Is the patient supine? Are they upright? Or sometimes they're too sick to sit upright and the film is obtained semi-upright. And then the orientation of the X-ray, which side is right and which side is left. And that is usually denoted with a big R or L on the X-ray, as we'll see. The next step is to look at the projection, and what we have here are two different projections of chest X-rays. One is an anterior posterior or AP chest X-ray. One is a posterior anterior chest X-ray, the PA chest X-ray. And if we look carefully at the anatomic structures, we can see the difference between these two projections. As denoted on the AP chest X-ray, the heart generally shows up a little bit larger, and in this particular X-ray, the cardiothoracic ratio is about 50%. That is, the heart is about 50% of the thoracic ratio. Comparing that with the PA chest X-ray, you can see that the heart projects much smaller and makes up much less of that cardiac thoracic ratio, so it's much less than 50%. And then again on the AP X-ray, the edges of the scapula creep in towards the midclavicular line, whereas on the PA chest X-ray you can see they're more out to the periphery. So the projection can affect the way that the anatomic structures appear and where they appear on the chest X-ray. The next thing that we want to do is look at the positioning and orientation. Again, is this patient supine, upright, or semi-upright? And what is the orientation of the film? And again, these are generally denoted on the X-ray. So if you look very carefully, you can see that how this was taken. This is an AP sitting or upright, and this is the right side of the X-ray, meaning that the other side is the left side in terms of orientation. And then the next step is going to be to address the technical quality of the X-ray. How good is the X-ray in terms of adequacy, rotation, degree of inspiration, and then exposure or penetration. So let's look at those elements. So why is adequacy important? If film is taken, and some films are inadequate, you may not have proper visualization of the important structures that are found on the chest X-ray. And so it's very important that when we look to try to address the adequacy of any chest X-ray, that you can see the following structure: the first ribs, the costophrenic angles, and the lateral edges of the ribs. So let's take a look at this chest X-ray. And Dr. Stevens, if you were being critical of this X-ray, what would you say in terms of the adequacy of the X-ray?
Well, this chest X-ray is inadequate. You're not able to see the entirety of the clavicle. You also are not seeing the complete course of the first rib. You're not seeing the lateral margin of the chest wall, so you may be missing stuff which is off the edge of the film, and you're also not fully seeing the costophrenic angles in this case, so you wouldn't be able to completely exclude a small pleural effusion.
So Absolutely. This is an inadequate film, and comparatively, if we were to shoot this film again and make it adequate, you can see all the things that Dr. Stevens was alluding to. Now the entirety of the first rib is seen. You can see the costophrenic angles denoted by the green checks here. And also the lateral edges of the ribs are also visible. So in terms of determining whether this is adequate or not, we can see all these three structures. So that's great. Rotation, also an important element of the quality of a chest x-ray. An x-ray that is severely rotated can lead to misinterpretation of the heart contours, the position of the trachea, and the actual appearance of the lung. So let's take a look at how we would evaluate rotation. If we're looking at a very well-centered PA chest x-ray, such as this one, the things that we want to do are find the medial edges of the clavicles, and I'm going to draw them roughly in here. We're going to find the vertebral spinous processes, and I'm going to draw those in here. And then these spinous processes on a properly rotated x-ray are generally going to be midway between the medial ends of the clavicles. And if we were to draw them in a little more clearly for you, you can see here are the medial ends of the clavicles, and then the spinous processes in blue, and you can see that the spinous processes lie in the midline between the medial clavicles. So this is a normal rotation of this particular chest x-ray. And then we want to evaluate the degree of inspiration. This often occurs. The patient may be expiring at the time the chest x-ray is taken, and it can really exaggerate the size of the heart and possibly lead you to believe that the patient might have an infiltrate or pneumonia when in fact it's all related to technique. It's very important that when evaluating the film for the degree of inspiration that you count the ribs. If you're looking at an AP view, you want it to count down to the 6th or 7th anterior rib in the midclavicular line. It should intersect the diaphragm. When we're talking about a PA view, you're going to count down in terms of posterior ribs down to the 9th posterior ribs. These are guidelines, but generally pretty good in terms of determining whether the degree of inspiration is adequate to evaluate the film. So let's take a look at some examples. So in this film, the lung bases are white, and Dr. Stevens, would you say that can you tell if there's consolidation there or not?
It's difficult because I'm looking at the anterior ribs, and so we've got 1 rib, 2 ribs, 3 ribs. We're not even seeing the 4th rib, and so it's an inadequate film. You can't really see the hemidiaphragm, particularly the left hemidiaphragm, very clearly in this example.
Mm-hmm.
So you'd be a little bit hard-pressed to say that there wasn't something going on here. So it's an inadequate inspiration, and you'd be worried about anything going on at the left base.
Could you comment on cardiomegaly in a patient like this?
Very, very difficult, because if they don't take an inadequate inspiration, often the heart can appear much larger than normal.
Great. And again, to just point out what Dr. Stevens had mentioned, when you're counting ribs, you can see you only get down to the 3rd rib. Ideally, you want to get down to the 6th or 7th rib in the midclavicular line. And again, we were concerned about, if we go back and look again, about consolidation there at that left base. And you can tell because of it's an expiration view, it's very difficult to make a call on that, and better to shoot the film again to get a better idea. And in fact, that's what was done. This is the very same patient, except this time it's an inspiration view, and you can see, what do you think of that left base now?
You can clearly see that the left hemidiaphragm is seen all the way to the vertebral margin, and you can see that there's no consolidation at the left base. And you can also see now that the heart is of normal size, so it's less than 50% of the transverse width of the chest.
Fantastic. And so you can see how important it is to get the proper view in terms of expiration or inspiration. You can be falsely misled to believe that the patient has cardiomegaly or potentially pneumonia when it's all related to technique.
And the only time we do take an expiration film on purpose is sometimes when we're looking for a pneumothorax. And so the time we purposely take an expiration film is when we're considering the patient has a pneumothorax, and most pneumothoraces actually increase in size on an expiration film and makes them a little bit easier to see. So that is one example where we would prefer to have an expiratory film.
Great. And again, counting our ribs, 1, 2, 3, 4, 5, 6. You can see we're down to the 6th rib and the midclavicular line, and no consolidation is seen at that left base. And then last thing that we want to do is evaluate the penetration or exposure. If an X-ray is properly penetrated, it's going to allow us to see structures behind the heart, like the lung. The patient may have a retrocardiac infiltrate or pneumonia, and also it will allow us to see mediastinal pathology as well. So again, here is an underpenetrated X-ray, and as we sort of move from lateral to medial, we sort of lose the left hemidiaphragm. It's not really visible all the way to the spine, as shown there. And again, if we're trying to determine whether a patient might have a pneumonia hiding behind their heart, it becomes very difficult when the X-ray is underpenetrated. What are some other issues with underpenetrated X-rays in addition to just evaluating for pneumonia?
You may not actually be able to see the vertebral margin, so you'd have to either window the film differently or to take a new film, because you should always, in a trauma patient particularly, be able to see the vertebral margins behind the heart.
And here is a properly penetrated film, and what you can see is that the diaphragm is clear, as the arrows indicate, all the way to the spine. The left paravertebral soft tissues are visible, and the right side of the spine is clear as well, as indicated by the arrows. And now that we can see clearly behind the heart, we can see that there is no infiltrate, there is no abnormality. So proper penetration, very important. In summary, when you're doing the initial evaluation of a chest X-ray, the things that you want to do, the 3 steps that you want to take, are always confirm the name of the patient and make sure that that's the patient you're interested in, and the date of the X-ray. Look at the projection, position, and orientation. And then in terms of quality, look at the adequacy of the X-ray, the rotation, degree of inspiration, and then the exposure or penetration. That's part 2 of how to read a chest radiograph. Thank you.